The purpose of this morning's meeting is to meet with the INMO and the Institute of Obstetricians and Gynaecologists in the first session and with the HSE in the second session in relation to the National Maternity Strategy 2016 to 2026, which was prepared by the Maternity Strategy Steering Group. On behalf of the committee, I would like to welcome to the first session Ms. Mary Leahy, Vice President of the INMO, and Mary Gorman, Executive Council Member of the INMO, and Dr. Peter Boylan, who is Chair of the Society of Obstetricians and Gynaecologists, and Professor Louise Kenny of the Institute of Obstetricians and Gynaecologists, who will provide us with their perspective on this key strategy document. Can I now ask Ms. Mary Leahy to make her opening statement?
Thank you, Chairperson, members of the committee. The Irish Nurses and Midwives Organisation has welcomed the launch of the country's first National Maternity Strategy, creating a better future together for the period 2016 to 26. Our midwife section has particularly welcomed the recognition within the strategy of the need to give pregnant women appropriate and informed choices, supported by access to the correct level of care and support for their individual needs. Our midwife membership has welcomed the recognition within the strategy of the role of midwives in the natural childbirth experience. In particular, we welcome the recognition of midwives leading and delivering care within the multidisciplinary framework for delivering the care pathway intended for normal risk mothers and babies. In that regard, we would advise the committee that every audit of existing midwifery-led units confirm high-quality performance and high levels of satisfaction felt by mothers. My colleague Mary Gorman to my left here with me has experience of such a midwifery-led unit as she works in Our Lady of Lourdes Hospital, Drogheda. Mary can further provide details with regard to the effectiveness and potential of this service model. In this regard, the publication of this strategy and, more importantly, its implementation should herald a move away from the current overly medicalised models of care in existence across the country. It has long been the view of the INMO that current maternity services underutilise the potential of the registered midwife, thus minimising the choices for the woman. It is imperative through the implementation of this strategy that our maternity services utilise the experience and autonomous practice of all healthcare professionals within the service in the interest of optimising the quality of the service and the supports to the mother and to the newborn. In that context, the organisation also fully endorses the recommendations within the strategy for the development of a community midwifery service. This development, which will see hospital midwives coming out into the community to provide ante and postnatal care, will represent a hugely positive development for mothers and babies, bringing the service to them rather than requiring them to come into a hospital for care and support. The INMO has also noted the intention to establish a National Women and Infants Health Programme to drive forward the implementation of the strategy over the coming years. Our organisation is on record as looking forward to working with this programme to implement, in the shortest possible time frame, all of the recommendations itemised, leading to a positive transformation of this country's maternity services. However, we are aware of difficulties in recruiting key personnel to lead this programme, which has delayed the pace of progress to date. The leadership issue is pivotal and must be addressed without delay. The INMO has sought a meeting with the Department of Health for the purpose of agreeing the necessary measures, particularly with regard to workforce planning, including an analysis of training needs necessary to ensure that we have the additional midwives required to facilitate the full implementation of this strategy. This meeting has yet to take place, but we do expect it shortly. It is now almost 1 year since the strategy was published, and the INMO, notwithstanding its excellent potential and the positive response the strategy has received from all stakeholders, is becoming increasingly concerned at the slow pace of implementation. A key example of this, which goes to the heart of maternity care, is the midwife-to-birth staffing ratio, which continues to exist in this country. The accepted midwife-to-birth ratio, which arises from evidence-based practice, is 1 midwife to 29.5 births. In fairness, the strategy commits to the introduction of this ratio over a number of years as maternity services evolve through the implementation of the recommendations. However, in the short term, it has proved extremely difficult to secure the additional midwifery posts necessary to improve the current ratio, which in some units continues to be in excess of 1 midwife to 40 births, and the average being 36 births to 1 midwife across the country. The latest HSE service plan refers to the recruitment of 100 additional midwives. However, we have yet to see this happen, and in particular, there is absolutely no certainty that even advertising these posts will secure the additional midwifery expertise required in hospitals and units around the country. In addition, the strategy will require increasing the number of midwifery posts by 100 for each of the next 4 years, but again, nothing has been done to recruit or to retain midwives in our health service, despite the current shortage, and we have no sense of proactive planning. The reality is that our current services are severely understaffed. From the experience of the INMO, there is a complete absence of workforce and manpower planning as to how this critical staffing shortfall will be addressed, and how will we ensure a supply into the future of midwives wishing to work in the Irish Public Health Service. This committee must understand the implementation of this strategy, which we believe everybody supports, is dependent upon an acceptance that as we remodel the pathways of care and provide choice for mothers, there will be staffing resource implications, particularly midwifery, which must be planned for, addressed and supplied. A fundamental requirement with regard to this workforce planning to realise and maintain this best practice ratio is to increase the number of direct entry undergraduate midwifery places by at least 25%, which is 125 student midwives, and in addition to expand the number of postgraduate midwifery places available across the country. The INMO believes this is self-evident, but if we are not aware of any plans to provide for this increase in supply. However, it must be noted that in recent years, a number of these postgraduate places have not been filled due to the lack of applicants. This is yet another example of the service-wide issue of recruitment and retention which must be addressed if we are to establish and maintain safe practice levels. On a more positive side, the committee should note that arising from a recommendation in the report of midwifery services in Portlaoise General Hospital, directors of midwifery have been or are being appointed to all midwifery units and hospitals, which are 19 in total. One important thing to note about these appointments is that the post of Director of Midwifery will, in the context of implementing the maternity strategy, have a remit which spans both the maternity hospital and the adjoining community services. This is most welcome and is indicative of what should happen as the strategy is implemented, and will provide governance to the enhanced community midwifery services referred to earlier. We believe this strategy, which was formulated after detailed discussion and debate involving all partners in maternity care, represents a step change in our approach to pregnancy and childbirth. The recommendations place the mother and child at the centre of all services and will require all members of multidisciplinary team to alter existing approaches to facilitate new models of care totally sympathetic to the mother and to the newborn baby. Implementation of the strategy is also essential in recognition of the changing demographics with regard to the age with which women choose to have children. Maternity services will have to be capable of addressing the modern-day realities of pregnancy, including increased levels of obesity, management of other chronic illnesses and the many issues which flow from modern-day work-life balance. This requires our maternity services to be resourced, responsive and flexible, which in fairness will result from the implementation of the strategy. We wish to acknowledge the dedicated work of the steering group leading to this forward-looking strategy. The INMO, and particularly our midwife section, commits itself to working with all concerned to deliver upon the strategy's recommendations. The collective goal must be to ensure excellent standards of care in the environment chosen by the mother based upon their needs and their preferences. The recognition of the role of midwives within the proposed new pathways of care is very welcome, and our midwife members look forward to embracing this change and providing these new models of care and choices for women nationwide. Thank you.
Thank you very much, Ms Leahy. Could I now ask Dr Peter Boylan, Chair of the Institute of Obstetricians and Gynaecologists, to make his opening statement.
Thank you, Chairman, members of the committee. First of all, I'd like to say that we in the Institute would endorse fully everything that Ms Leahy has said in respect of the role of midwives, and are fully supportive of what she has said. And the Institute of Obstetricians and Gynaecologists welcomes the National Maternity Strategy and hopes that it will be implemented. There are three areas which the Institute is particularly keen to see implemented without further delay. The first is that we wish to see the mastership model of governance applied nationwide, with each unit having its own separate budget and governance structure. This model has been in operation in the 3 Dublin maternity hospitals for more than 200 years. It is a tried and tested model which works. A clinician is effectively the CEO and is assisted by a Director of Midwifery and a General Manager who has the appropriate financial and clerical support. The Master is ultimately responsible for the quality and safety of the service and is therefore accountable. With that accountability goes authority to operate the service in the best interests of patients, that is, women and children. There's an identifiable person who is answerable for the quality of the service. Experience in the United Kingdom has shown that the further away from the patient the governance structure is, the more there is an emphasis on financial outcomes and less on clinical outcomes. The current governance model, whereby maternity units around the country are integrated into the general hospitals, is a failure. Recent problems in Cork and Portlaoise are good examples of this, and this failure has been demonstrated repeatedly over the past several years by well-documented tragedies. There is no budgetary protection for maternity services, including gynaecology, and so they are the first to suffer cutbacks in our hospitals. Secondly, we wish to see all units have access to expert ultrasonography services for all pregnant women. At the moment, there is a huge variation in availability of ultrasound for pregnant women around the country, and this has serious implications for the quality of care which can be given to women in pregnancy. We wish to see an increase in consultant numbers to bring us up to internationally accepted norms. It is well recognised and accepted that the number of specialist obstetrician gynaecologists in Ireland is the lowest in the developed world. There is a need for an additional 100 consultants to bring us to an acceptable level. There are other elements of the strategy which the Institute would like to see developed, such as more community-delivered antenatal care closer to women's homes. Again, learning from experience in the UK, it is essential that obstetricians and midwives work together as a team and not separately. Finally, there is no mention of gynaecological services in the National Maternity Strategy. This is a serious deficiency, and a national gynaecological strategy needs to be developed.
Thank you very much, Dr. Boland. Could I finally ask Professor Louise Kenny, Professor of Obstetrics at University College Cork, a consultant obstetrician and gynaecologist at Cork University Maternity Hospital, to make a opening statement.
Thank you. Thank you, Chairperson, and thank you to the committee for this opportunity. I too would just like to echo what my colleagues have said. We must accept the fact that the woman is at the heart of everything that we are addressing today, and not lose sight of that. Notwithstanding that, my colleagues and I at the Institute of Obstetricians and Gynaecologists welcome the National Maternity Strategy, and we sincerely hope that it will be adequately resourced and fully implemented without further delay. There are fundamental inequities in the provision of women's healthcare in Ireland in 2017. Firstly, Ireland has the lowest number of obstetricians and gynaecologists among the OECD countries, at a rate of just 3.95 per 1,000 live births. This is just over half the comparative number in the UK, for example, for the same number of births. But despite this, clinical outcomes for mothers and infants are comparable with the best internationally. We urgently need to recruit a minimum of 100 extra consultants. However, this will require remedial steps to retain our senior trainee specialists who are currently discouraged from remaining in Ireland by poor working conditions, the perception of a hostile media, and gross inequality of remuneration and contracted hours, which has been brought about by the introduction of the divisive 2012 consultant contract. Secondly, we once again reiterate the need for equal access for all women to standardised ultrasound services. At the current time, neither specialist ultrasound or fetal medicine services are available to all pregnant women in the Republic of Ireland. Even in CUMH, where I work, a tertiary referral unit where over 8,000 infants are born every year, we cannot provide second trimester fetal anomaly scanning for the majority of pregnant women attending for antenatal care. This issue remains unresolved in 2017 and exposes pregnant women attending CUMH and their healthcare providers to an unacceptable level of risk. Finally, the single most important step to safeguard the success of the National Maternity Strategy is to ensure that the governance of women's health services is robust, independent and secure. International experience demonstrates that women's health services are always the first to be cut when they are not protected by an independent governance and a ring-fenced budget. Closer to home, the well-documented issues with the provision of gynaecology services in CUMH, which have led to unprecedented and dangerously long waiting times for both outpatient and surgical treatment, further illustrate this point. We believe that in keeping with the National Maternity Strategy, maternity services within the Irish hospital system need to be led by a single accountable individual with both clinical and executive authority. Thank you once again for the opportunity to be here today.